The patient should be positioned supine with neutral head alignment. Clip the patient's hair where the ventricular catheter will be placed. Most commonly, this will be Coker's point in the right hemisphere. Mark the location of Coker's point. This is usually found 10.5 to 11 centimeters back from the nasion and 2.5 to 3 centimeters lateral to the midline, which usually corresponds to the mid-pupillary line. An alternative method is to feel for the coronal suture and mark a spot 1 centimeter anterior on the mid-pupillary line. Clean the area with an iodine-based product and wait for the solution to dry. Draw up your anesthetics using a 10 ml syringe and a 22 gauge needle. Change the needle over to the 25 gauge size. Inject the anesthetics down to the skull where Coker's point is marked. Do this before setting up the sterile field to allow time for the anesthetics to be effective and aid in hemostasis during the procedure. Also inject an anesthetic along the path where the ventricular catheter will be tunneled. Open up the cranial access kit using sterile technique. This will be the sterile field where other supplies such as the ventricular catheter will be dropped. Note: an actual procedure would be performed observing sterile technique. For this demonstration video on models, sterile technique will not be used. Locate the desired drill bit and determine the penetration depth, then tighten the depth guard with the hex wrench. Place the desired drill bit into the drill and tighten. Ensure that the patient is appropriately anesthetized and sedated. Make an approximately 1-inch incision in the scalp down to the skull using the number 15 scalpel blade at Coker's point. Open the incision with the self-retaining retractor. Holding the drill at a 90-degree angle perpendicular to the skull, drill a burr hole using gentle pressure. Once through the first layer of compact bone, the drilling will become easier through the cancellous bone. Once the inner table of the skull is reached, it will become more difficult to drill through. Apply slow, manual drilling through this layer to prevent plunging into the brain. Use a pair of forceps to remove any bone dust or chips, as these can get passed into the brain tissue during catheter insertion. Once the burr hole is made, use a needle or number 11 scalpel blade to puncture the dura. Take the ventricular catheter with the guide wire in place and advance it slowly but steadily through the burr hole into the parenchyma. The trajectory should be towards the ipsilateral medial canthus of the eye, and the catheter should be exactly perpendicular to the skull. Advance the catheter 5.5 to 6 centimeters from the dura mater. Pull back on the stylet and assess for cerebrospinal fluid pulsations in the catheter. If no CSF is seen, pull the catheter out and replace the stylet after washing down the tip of the catheter with a sterile solution. This will remove any debris in the tip of the catheter that may prevent flow. In general, a maximum of 3 passes should be attempted. Once CSF is obtained, attach the extracranial end of the catheter to the trocar tip, being careful not to inadvertently pull the catheter out of the ventricle. Using blunt forceps, pinch the catheter at the skull with your non-dominant hand. Then tunnel the trocar along the access path below the galeal layer of the scalp a minimum of 5 millimeters from the burr hole. The ventriculostomy catheter should sit firmly down as you pull the other end through the scalp. Cut the catheter off the end of the trocar. Attach the lure connector to the catheter. Place a closed cap on the end of the catheter to prevent CSF from leaking. Using 3/0 nylon or Prolene sutures, place a drain stitch at the point where the catheter exits the scalp, being careful to not place a stitch through the catheter or make it too tight. Close the incision with 3 or 4 interrupted sutures. Gently wrap the catheter along the head and secure it with a transparent dressing. While still sterile, have the nurse assistant hold up the connection tubing of the drainage device. The drain should be primed by the nurse with preservative-free sterile normal saline before connecting to the ventricular catheter. Remove the cap from the catheter and connect the end of the catheter to the tubing. Tie a silk ligature around the area where the tip of the tubing connects to the catheter to prevent it from becoming dislodged accidentally. Provide ICP monitoring orders to include the following: height of the burette, intermittent or continuous drainage, and dressing preferences. We hope you have found this video to be a useful guide. Again, local hospital protocol should be followed. For further information regarding the use of our neuro products, please visit our YouTube channel or visit our training academy.